Good afternoon, everyone. Again, my name is Arne Valedon. I am the medical director for outpatient perioperative services as part of Wellspan Health in Pennsylvania, United States. And I'm also representing the Ambulatory Surgery Center Association located in Washington, D.C., in the United States. First and foremost, I would like to thank the rest of the scientific committee members who have put together an excellent conference, as well as our president, uh, Doug McKinney from the UK. Thank you very much again for putting together an excellent set of topics on a very timely pandemic time that I believe will be with us for a little while to come. So thank you again, and we certainly hope that we can engage in a discussion at the end of all of our topics that will be relevant to everyone. Our topic today is going to be COVID-19 positive conversion after elective surgery, to wary or not to wary. I have no disclosures, financially or otherwise, to declare. And what we have in front of us is a dashboard that has been put together by Johns Hopkins University in Maryland. It's a dashboard that has been used again around the world, one of several, but one that is fairly comprehensive. And this is again via background. We currently have about close to 40 million cases of COVID around the world, close to 1.1 million deaths. As we can see from the map, just about every country, banning a few in the world, have been affected by COVID-19. Banning, again, maybe Antarctica and some of the outlying territories in some of our countries around the world have been affected. And it is my opinion, as you probably would agree as well, that this is with us for some time to come. So certainly challenging times. Now you might ask, why should we worry? What is the clinical significance of converting to a positive status after elective surgery? I must start by saying that the data that we have regarding complications rates, as well as mortality after surgery, especially when it comes to COVID-19, is limited. It is emerging, and it's emerging quickly. Uh, Again, we have surgery being done around the world with patients that might or might not be COVID positive. So the data is there, it needs to be collated, and more research is needed. At this point, the data is limited. Um, Also, with respect to testing capability, we know that around the world we have variable testing availability, as well as tests that are sufficiently sensitive and specific for the disease. The issue of testing preoperatively also variable, as well as potentially testing postoperatively or at a bare minimum, following the status of patients postoperatively, is something that I would like to discuss with you during this presentation. Now, we know that the evidence that at least the CDC in the United States has been able to put together for us with respect to increased risk for severe COVID-19 illness is associated with certain diagnoses. The strongest and most consistent evidence that we currently have is with patients that have COPD, patients that have cancer, patients that have type 2 diabetes mellitus, sickle cell disease, solid organ transplantation, as well as some serious heart conditions. Not all, but heart failure, coronary artery disease, and cardiomyopathies. Now, not all data, again, is strong and consistent as the first group. So we have some mixed evidence for patients who have hypertension, pregnancy, asthma, using corticosteroids, smoking, and using immunosuppressive medications. Very limited evidence to date regarding HIV, liver disease, pediatrics, thalassemia, and bone marrow transplantation. So I fully expect that we will know more in the months and years to come regarding this. Now, with respect to postoperative mortality as well as perioperative complications, what do we know at present? Well, we do know, and again, limited, but we do know that patients undergoing surgery who have COVID-19 confirmed within 7 days before or 30 days after surgery have worse morbidity and mortality. And I'd like to share with you some of the data that we have so we can have a discussion and come up with some practical pathways so we can move forward. The largest retrospective study out there and analysis to date includes 1,128 patients. This is from 24 hospitals around the world. And the study took place between January 1st and March 31st, 2020. In this group, just about 74% of patients had emergent surgery. Roughly about 25% had elective surgery. And out of the patients who had surgery, 26.1% had confirmed COVID-19 preoperatively. Out of that group, the 30-day mortality was close to 24%, and pulmonary complications was roughly about 51%. Out of that group, specifically, the 30-day mortality was even higher, it was about 38%. Again, fairly significant numbers. In the adjusted analysis in that group, what was noted was that 30-day mortality was associated with 6 major conditions. Male sex, ASA status, 3 to 5, as opposed to 1 to 2. Age 70 or above. A malignant versus benign or obstructive diagnosis. Major versus minor surgery, as well as emergency versus elective surgery. And I have something to say about that. It's an important note regarding elective surgery. Even though the mortality and the pulmonary complications showed higher statistical significance for emergency cases, what the data tells us is that there is still significant mortality in the elective surgery group. In this cohort, close to 19%. Again, these are thousand-fold mortality rates that we're used to seeing for elective surgery. So even though in comparison it's lower, it's certainly plenty significant. Also, we know from that group that a higher percentage of mortality was observed in those who had a postoperative diagnosis as opposed to a preoperative diagnosis. The pulmonary complications, again, follow the same pattern as mortality. And there was also observations of thrombotic complications in those patients. So again, in summary, certainly mortality, way higher than we're used to, pulmonary complications, as well as thrombotic complications. So the original question that we had was, do we worry about this COVID positive conversion or do we not worry? And the answer is we do need to worry about it, unfortunately. So what do we do? One of the questions that comes up, of course, is why are we observing these trends? And there are several theories out there. We don't know 100% what yet, but we do know that patients that are undergoing surgery have a pro-inflammatory response under the cytokine pathway, as well as immunosuppressive responses to surgery and mechanical ventilation. That is well known. So it is theorized that surgical patients that have COVID-19 would be, again, at a higher risk of potentially having these complications and potentially explaining the increased morbidity and mortality that we're observing. Now, coming over to the practical side, what do we do if we have an unresulted patient on the day of surgery? I am sure this is something that we're faced with, many of us, on a daily basis. I can tell you that what is about to follow are guidelines, and clinical judgment should supersede any kind of guideline wherever we are. So again, very important. Who should we not proceed with? Again, these are my observations as well as the opinions of others, but again, guidelines, not standard. When should we not proceed with surgery when we have unresolved patients, knowing what we know now? about postoperative complications? Well, certainly, if the patients are having elective or semi-elective surgery that can wait, we should probably not proceed with that. Number two, patients that have uncontrolled morbidities, particularly if they're listed on the groups that we discussed above, for which we have strong evidence, potentially limited or mixed evidence, and are in any of the categories that we just saw in the study. Again, male sex, age over 70, ASA physical status 3 to 5, and malignant diagnosis or major surgery, it would probably be a good idea to hold off. And I have a quick comment. Thank you, Dr. Litonius, for having this discussion with me. And that has to do with malignant diagnosis. What does that mean? Well, that means typically that a patient has cancer. So you might argue, why should we wait to proceed with surgery when somebody has cancer? We all know that cancer comes in many different forms. There's a lot of clinical judgment that comes with this. Clearly, if this is a slower growing cancer and the testing would be done in a day or two, potentially 3 days, it is reasonable. If this is something that, if the diagnosis is fairly malignant, in a few days will make a difference, certainly we should not proceed with surgery. Of note, again, patients with a benign or obstetric diagnosis, having elective surgery or minor surgery, have lower complication rates and mortality when compared to malignant diagnosis, emergent surgery, but certainly not zero, as I shared with you before. So when should we proceed, you might ask? Well, certainly patients with a life-threatening injury coming in for emergent interventions, patients with no comorbidities and undergoing a low or intermediate risk procedure, or patients with controlled comorbidities and undergoing a low or intermediate risk procedure and not in any of the categories, the 6 categories that I mentioned previously, 5, I should ask, in the previous slide. So again, a lot of clinical judgment goes with this. These are the references that we have in front of us. I can tell you the papers number 2, number 3, and number 4, that they're all listed here for you, but very enlightening when it comes to this topic. So I very much look forward to a discussion, and I thank you.